we are extremely privileged to have Professor Sushil Gupta as today's speaker for our webinar series in ASTHI program. Professor Gupta is a professor of SGPGI Lucknow in the Department of Endocrinology. Professor Gupta's research interest is osteoporosis and metabolic bone disease, as well as endemic fibrosis, acromegaly, and renal stone disease. Professor Gupta is a prolific researcher, evident from his publications, which the count comes to 102 and almost a dozen of chapters in book. Professor Gupta is also in various committees of Government of India, particularly in the Department of Biotechnology, where he is member of the Apex Committee, member of Ramalinga Swamy Re-entry Fellowship Committee, and he is also currently Vice President of Indian Society for Bone Mineral Research and ex-Vice President of Endocrine Society of India. And last but not the least, he is the founder secretary of UP chapter of Indian Society for Bone Mineral Research. With this brief introduction, I invite Professor Gupta to deliver his webinar today. His title is Calcium Deficiency and Bone Disease, a clinical and experimental perspective. Professor Gupta, the platform is
Thank you, Navadya. Thanks to the study group to be. I'm really privileged to be part of this group. Of course, I haven't attended any of the meeting, but I'm sure that it must be the most informative meetings uh, we have in academics. Actually, I would be discussing my thought process over calcium deficiency induced bone disease, a clinical and experimental perspective. Basically clinicians. And we have done some research work in association with Dr. Navadya Ritu's team at CDRI, and a lot of experimental work was done by my PhD student, Dr. Shimurat Yadav, who is currently now in US. Calcium deficiency is a very, very important clinical phenomenon now. It's being acknowledged in third world countries. As we know that calcium is a major macronutrient, and it is very, very essential for bone modeling and remodeling throughout all the ages actually. In the young age, we form the bone, then we maintain the bone, and then at the later age, we prevent the loss of the bone. At all the stages, calcium is extremely important as a major nutrient. So in the early age, the calcium nutrition is important to achieve the adequate bone growth, to achieve the peak bone mass when we gain the adulthood. We make the good microarchitecture. And in elderly people, when there's a gradual bone loss, either because of menopause in the woman or in the man also, we lose the bone. And adequate calcium intake is important to retard the rate of loss of bone at this age. Actually, we have been talking of nutritional rickets or osteomalacia. Basically, we talk of two things. We talk of calcium and vitamin D. Both are important, but the problem is that both are equally important, or which one is more important. Osteomalacia can be caused by either of these two deficiencies or a combination of them. You can have a calcium good nutrition, but when the vitamin D is deficient, you can have rickets osteomalacia. On the other hand, you can have isolated calcium deficiency, and then you can develop osteomalacia or rickets. But usually, the clinical practice, both are common, and when both are common, the features come early and more prolific. For ages together, in general concept, we think that calcium deficiency is not there, but it is widely recognized that we have got inadequate calcium intake practically globally. Actually, we know that vitamin D deficiency is rampant in our country and across the world. Various studies done by various groups across the country have shown that almost 70% of Indian population, right from the newborns till the old age of 80 or 90 years, they are vitamin D deficient, almost 70%. Only about 90% cases, only 10% of the cases have got normal vitamin D. That speaks high of the extent of vitamin D deficiency. Now, when we look at calcium deficiency, this is a very excellent survey published in 2017 about calcium intake in 174 countries. The average national dietary calcium intake ranges from huge wide range from 175 to 1233 milligrams per day. Majority of Asia has got less than 500 milligrams per day, which is very, very suboptimal. Africa and South America, about 400 to 700 milligrams per day. European countries usually have good calcium intake, more than 1000 milligrams per day. And this calcium deficiency is more prevalent in women than in men. This is a global map given by these workers, which shows that the extent of calcium deficiency across the globe, as I said earlier. Asian countries is less than 5. You can see here, less than 500 milligrams per deciliter per day. And European countries have got much better calcium intake. There have been recommendation for daily intake of calcium across a lifespan. It is about two in the, both have got different requirements because of growth pattern also. Like in males, it is in the early age it is 200 to 700 milligrams per day from 1 to 3 years. Because a rapid spurt in the growth, you require much higher dose of much dietary intake of calcium, like 1000 to 1300 milligrams per day, to maintain the bone intact, to prevent the loss. It requires 1000 milligrams per day from 90 to 70 years of age in man. After 71 years, because calcium absorption reduces from the gut, actually you require high calcium intake, which is around 200 milligrams per day. When we compare the RD of calcium in the as compared to the females, it is almost similar to the age of 50 years. But at when the age of 51 to 70 years, because we have got menopause, there has a loss of estrogen because of menopause, and we very well know that estrogen increases the GI gastrointestinal absorption of the calcium. Therefore, the requirement goes up of the menopause, and therefore we have got increased RDA of 1200 from 51 years of age onwards in females. Uh, Calcium deficiency is not a very recent phenomenon. Actually, the first description we reviewed the literature, when was it described first? And actually, while looking at the old papers, actually, it was described in 1929 from India itself. Uh, Actually, it was a work of Professor Ella Suri and Dr. Wilson. Professor Ella Suri was a professor in Delhi Medical College, and he described osteomalacia latent rickets among women and girls in the northern India. And actually, Dr. Wilson reported rickets in various forms, which is infantile and late rickets in northern India and Kashmir. I have specifically mentioned the word written in this paper actually. In towns wherever there is deficient sunlight combined with unbalanced diet, here he is speaking of Kashmir, and in rural areas where he plentiful sunlight cannot compensate for a diet quantitatively and qualitatively deficient. He is talking of Punjab here. So these are the two areas discussed, described from there actually. He described 400 cases of late rickets and osteomalacia. Majority of them were less than 17 years of age. That's the growth age, actually, growing age. 160 were with deficient diet. This is probably calcium deficient rickets actually. 240 had probably predominantly poor sun exposure. This is most likely vitamin D deficiency. And 209 poor food quality and quantity due to lower social status, probably because of poor calcium intake. The most important thing, the next paragraph really clearly says that it was observed that diet that is milk and fruit, led to little improvement in symptoms if sun exposure was limited. Actually, interestingly, the keen observation was that the provision of sunlight for cases on deficient diet is of no avail. This statement extremely important. I would really give credit to him for this keen observation that if the diet is deficient, you give much of the amount of sun exposure, it does not heal the bones actually. And this additionally, the patient requires gradually improve vitamin D full doses, but the use of a moderate vitamin D doses daily with the sunlight and improved diet is recommended to achieve more rapid results. So he clearly demarcates what to be done with the calcium deficiency diet induced rickets osteomalacia and what to be done what vitamin D deficient or sunlight deficient rickets osteomalacia. This is a description given by Taylor actually 1939 and 40 from Palampur, that is district Kangra, Punjab, pre-independent India. Actually, district Kangra is very important. For the first time, I realized that though we know that it is the area which was highly iodine deficient, and Dr. Ramalinga Swami was carrying out the survey of goiter, iodine deficient goiter in this area. So Palampur also takes the credit of defining calcium deficiency actually. 25% of children and 50% of women had rickets or osteomalacia. Diet has poor or no milk intake, while the children wore a few or no clothes, and there was no parda. Being a Hindu community actually, so parda was not there. This implicated that these children and women had sufficient sunlight exposure for vitamin D synthesis. So this is a really good description of what is calcium deficiency rickets oblique osteomalacia means to us. And in 1938, Ackroyd and Krishnan carried out a first interventional trial of calcium supplement in India. In 1938, he supplemented calcium lactate 0.5 grams to diet of young South Indian children ranging from 2.5 to 7 years. This was added to diet of rice and millets, which with practically no milk, with from poor families in Kunur, South India, for 4 to 5 months, and it yielded significant increment in the height and weight as compared to controls in India. And similar results were reported in the same group of children in older children with the skin milk. So this is the first intervention trial of calcium supplement in India in calcium deficiency rickets. Other studies showed that there could be calcium deficiency induced hypocalcemia as proven by positive chapstick sign in Indian girls and young women, despite abundance of ultraviolet rays and sufficient UV exposure of the skin. In these children, the diet was very poor and dairy products and calcium sources were available only in the form of cereals and leafy vegetables. Early description of high phytates and high oxalates reducing the anticipated absorption given as early as 1939. Very interesting actually. Now, subsequently, if you look at the literature, it was further described in this vibe of Walker in South African Bantus, adults actually with the calcium intake was very low from 175 to 475 milligrams per day, with only 5% consuming 500 milligram or more per day. So extremely deficient calcium diet in these Bantus adult actually. And these persons had adverse calcium to phosphorus ratio, greater ingestion of phytic acid, high consumption of light millet cereal, lower protein intake, and loss of calcium through perspiration. The first scientific paper was described by Patty Fur from South Africa, where they described 9 children ranging from 5 years to 13 years of age, and they had a classical calcium deficiency rickets actually. And if you look at the picture, these are the widths or bony deformities with a thickened fora, the wrist joint. And this was a picture, early picture before the calcium supplementation, the rickety picture showing the widening, fraying, and cupping of the distal end of the radius and ulna. And after calcium supplement for 3 to 5 months, there was a distinct healing in these areas. This is a biochemical profile of these children on calcium supplementation of 1000 milligrams per day. There was a gradual decline in the alkaline phosphatase over a period of 3 to 6 months' time. Uh, there was progressive rise in the serum calcium levels. Serum phosphorus also raised during this period. Urinary calcium, if you look at the early, before the treatment, it was very low, and then gradually it's picked it up, and the calcium, the cyclic AMP, urinary cyclic AMP was progressive, reducing in these subjects. After this paper, lot of publications came from Africa, especially Tanzania, from India, from our departmental colleague, Dr. Vijay Lakshmi described calcium deficiency. From Bangladesh, again, Fletcher described, and they documented rickets oscillation. Children are extremely low dietary intake despite uh, having adequate vitamin D status. So we discussed calcipenic ricket. And subsequent studies showed that dietary calcium deficiency deteriorates bone microarchitecture, reduces bone mass, longitudinal growth, trabecular density, mineralization along with the increased resorption and osteoid volume, thus resulting in osteomalacia in growing animals. Subsequently, a lot of other studies from the animal models showed a similar kind of picture actually. And in 2005, Dr. Milan Malhotra, she did another study of calcium deficiency in growing rabbit pups. Uh, so calcium deficiency reduces the bone mineral density in growing rabbit pups, and it was rapidly reversible with calcium supplementation. So overall calcium deficiency is caused by dietary calcium deficiency, which is further compounded by pregnancy, lactation, physical growth, impaired calcium absorption, and high renal excretion, and it can result into hypocalcemia, poor bone accrual during growth, low peak bone mass, impaired growth, recurrent osteomalacia, risk of all fractures, and osteoporosis. Uh, lot of other papers, animal model papers were there. Then this was a paper I was describing this calcium deficiency into secondary hyperparathyroidism and osteopenia are rapidly reversible with calcium supplementation growing rabbit pups. The we did not have at that we had an access to bone mineral density measurement by DAXA, and we proved that the poor bone quality is there in these growing rabbit pups actually, but we could not go further what really happens to the microarchitecture and bone strength. So the most important issue is when the majority of the country is passing through a phase of calcium deficiency, we expect a lower peak bone mass. In another study, we showed that almost 70% of adults, Indian adults staying in Lucknow, between the age of 20 to 30 years of age, have low peak bone mass as compared to Caucasians, actually, which is a large number. In another study, we showed that almost 40% of postmenopausal women above the age of 50 years have got osteoporosis. This is in contrast to the Caucasian data, which is already 20%. So we have got twice the prevalence of osteoporosis in women after the age of 50 years. Similar thing happens in the males also. We have got a prevalence of osteoporosis at about 40% of elderly males more than 60 years of age. This is in contrast to the prevalence of osteoporosis in Caucasian adults, Caucasian population more than 60 years of age, around 10%. So 10% in males and 20% in females in Caucasian, versus 20% in males in Indians and 40% in Indians in women. So we have got a high prevalence of osteoporosis. So the question arises, are we seeing this picture of calcium deficiency, which is reflecting in the peak bone mass in the adults and the high prevalence of osteoporosis in the elderly people also? Second question is rickets and osteomalacia reversible? That's another question. The question is this one, that suppose if you got a calcium deficiency in early childhood and we really pump in calcium dye to these children, are we reversing rickets osteomalacia to the completeness in these children? Number one. Number two is, what is really happening to the bone strength actually after replenishment? Is there a complete recovery of bone microarchitecture? Are the biometric properties are getting back to the normal? And what really happens to mechanical strength? The issue is the BMD does not reflect the strength of the bone in totality. It reflects about 70% of bone strength. That's true. But microarchitecture How does it define? So we reproduce this kind of this picture that by inducing calcium deficiency in the early growing age of rat pups, then following these and supplementing with the calcium in a normal diet or maybe probably super physiological diet, and really what happens to the bones in these people, these rats, what happens to their growth, what happens to bone and mineral metabolism, what happens to the bone microarchitecture, what really happens to the strength. So these are the questions we try to answer this study actually. So we assess the effect of low calcium diet, which we chose as a 0.1% versus normal calcium intake, which is 0.8%, and bone accrual, peak bone mass, microarchitecture, bone strength, the dynamic bone histomorphometry in growing rats, and to see assess the reversibility of these changes with adequate calcium supplementation in calcium deficient rats. So we had the diet of from AIN 93G diet and two formulations. What is control diet is 0.8% and calcium deficient diet in 0.1%. There's a lot of controversy about what should be the normal calcium diet, normal calcium content in a normal diet of rats. We found a figure of 0.25% to 0.8%. So we chose not to have an error of 0.8% as a control diet and 0.1% as a deficient diet. Second issue, we try to address this calcium supplementation, the rat ages with the human age actually. We in the literature search we found that the weaning rats, which is at P28, the 28th of the days after the birth, it corresponds to the human of 1 year. The P70 is young adulthood for the rats, and it corresponds to the 13 years of human, which are adolescent actually. And growing adult is 150 days in the rats, which corresponds to 90 years of human. And scattered maturity is 210 in rats, and it's around 23 years of human. So we try to replicate the calcium deficiency in the rat as corresponding period to the human, that is 28 to 70 days is a rapid growth period actually of young adulthood, then 150 days for growing adult skeletal maturity. So we replicate this experience design as this, that at 28 days we took the weanling rats, that is 1 year of age of human, then we divided into randomized to two groups. Control group was carried by and study point was 70, 150, and 210, and other group was calcium deficient diet, that is 0.1%. They were given in the 70 days of age, and then they were recategorized to receive calcium deficient diet or calcium reference diet. And this study was carried till the age of skeletal maturity actually. We carried out urine examination in these rats at various time points of calcium, phosphorus, creatine, and urinary cross labs. These rats were sacrificed, blood was taken. We looked at the bone and mineral homeostasis like ionized calcium, corrected calcium, serum phosphorus, alkaline phosphorus, vitamin total, P1NP as a bone formation marker, and rat specific intact PTH. And we extracted the bone, femur, tibia, and L5 vertebrae. We carried a microCT in volumetric BMD at all these sites. We carried out in addition at a femur 3-point bending test. 3-point bending test. Uh, Femur had compressive strength, dynamic stomophometry, GT staining, X-ray diffraction, and scanning electron microscopy. We looked at L5 vertebrally compressive strength. So major focus was to look at beyond bone and mineral homeostasis, looking beyond aerial BMD. We are now looking at a volumetric BMD. We are looking at a microarchitecture of bone, and we are looking at a bone strength in addition to that. And and at the same time, we are looking at further submicron levels like X-ray diffraction and scanning electron microscopy to see the distribution of hydroxyapatite crystals. So it is a limited formation, but also a really very useful formation interpretation. So just a moment. So when we look at both body weight and food intake in these controlled rats, calcium deficient rats, and replenishment. As I said earlier, at 70, we randomized a calcium deficient rat into two groups. One rat was continued to calcium deficient, and other rat was continued 0.8%. There was no difference in the food intake between these three groups. But if you look at a body weight, uh, the the calcium deficient rat continue to have a lower body weight till the P210, while after the P70, they were replenished with the calcium 0.8% of diet. There was a progressive increase in the body weight, which got as close to the normal rats actually. So calcium deficiency induces weight loss till 210 days of age. We looked at a bone weight and bone length, and we realized that at P70, the, in the calcium deficient group, the femur weight was significantly lower as compared to controls. Tibial weight was lower, femur length was lower, and tibial length was lower. So calcium deficiency induced all these things. When at P50 also, all these factors were, all these femur weight, tibia weight, femur length, and tibial length was significantly lower. Again, at 210 days, it was almost similar. But if you look at a calcium deficient, when the rats were replenished with the calcium 0.8%, the tibial was significantly lower as compared to the control group. So this is all the parameters improved, but the tibial length remains lower than control group. When we look at the biochemical parameters, densitotropic hormones, and bone markers, one can see the serum biochemistry in the terms of ionized calcium, corrected calcium, and serum phosphorus. One can see that this is a line which shows that there is a progressive increase in the ionized calcium and the controlled rats. But when the calcium deficient rats had significantly lower ionized calcium levels. After replenishment of calcium at P70, there was a progressive rise in the serum calcium levels in the ionized calcium, and it was a little higher than the control group. Similarly, the corrected calcium also, there was a resumption of serum calcium levels on the establishment of calcium rich diet in these rats. Phosphorus, this is interesting actually. On calcium deficient rat had a significant lower serum phosphorus levels through the point of study, but when these rats were replenished calcium, the serum phosphorus did not rise and never got close to the control group. So these rats, despite calcium supplementation, continued to have hypophosphatemia, and it was not related to serum PTH. When we look at the PTH level of vitamin D levels, the vitamin D levels across the whole study period was comparable in all these three groups. When we look at the PTH level, in general, the control rats had a progressive decline in the rat PTH level till 210 days. But when the calcium deficient diet was given till P70, there was an increase. But even after continuation of calcium deficient diet, there was a progressive decline in the PTH level, calcium deficient diet. But on replenishment at P70, there was a sharp reduction in the serum PTH level, and it almost reached the control level. So one thing we can say that PTH level normalized, but still the hypophosphatemia persists, and there was no evidence of vitamin D deficiency. Looking at urine biochemistry, these bars are the bars of the control, and this is the calcium deficient. One can realize that as compared to the controlled rats, uric and urinary calcium will continue to be lower in the calcium deficient rats. Or replenishment of calcium diet into at P150 and 210, there was an increase in the urinary calcium levels, not to the tune of normal, though it was not statistically different, but there was a trend to normalization of urinary calcium level because of bone remodeling and more need of calcium in the bone mineralization. Look at the serum phosphorus levels. The urinary phosphorus was significantly higher in the calcium deficient rats. On supplementation of calcium, there was an increase in the urinary phosphorus, and it's at 150, and uh, and little higher than normal at 210, though not such different. So so I would say that these rats had uh, continued to have hypophosphatemia and increase in the urinary phosphorus levels of phosphaturia despite normalization of PTH levels. Looking at both formation, both resorption markers, we looked at alkaline phosphatase, serum urinary CTX, and serum P1 and P level. There was a progress in the control rat. There was a progressive decline in the ALP alkaline phosphatase levels, and the alkaline phosphatase in the calcium supplementary group normalized to the normal levels at 210. Again, the similar picture was seen with the urinary CTX levels. The CTX levels in the calcium after calcium replenishment reached up to the normal. Looking at P1 and P, the also P1P level, P1 and P levels normalized after the calcium supplementation. Now, what happens to the bone mass, microarchitecture, and strength? This is a distal femur trabecular bone, and we did the macro CT. Thanks to Dr. Navaidya for carrying out all these studies at his place. Uh, this is a distal femur trabecular bone at the P28. And you look at the control, very good, strong trabecular bone with a very good connectivity we have. But in the calcium deficient group, one can see really torn apart trabecular structure. And this, when the calcium replenishment was done, there is a recovery, but it is not good recovery at par with the normal control rats actually. When we analyze these subjects, typical parameters, volumetric BMD, BV, TV, typical numbers, connectivity density, typical separation, typical thickness, SMI, and typical perforation. There was in, resumption, there were the calcium deficient, the rats who were in calcium deficient diet, they continue to have all these parameters very poorly, but calcium supplementation did improve these parameters, but not really completely. Look at the BVTV, it still remains lower than this thing. Similarly happened with the volumetric BMD, trabecular numbers, connector index, trabecular thickness, trabecular separation, SMI. So there's a disparity in all the parameters, but majority of these parameters show that there is a failure to achieve the normalization despite calcium supplementation at P20. Similarly, in the proximal TB and tubercle, we had almost similar findings in the trabecular bone and showed the same kind of pattern. Calcium replenishment improved the volumetric BMD, but failed to improve the bone BB-TV. They're still much lower. Trabecular number is still much lower. Connectivity index density much lower. Uh, Trabecular separation much lower. And similarly here also, trabecular perforation much lower. So there is an incomplete recovery of the trabecular bone microactive structure. Looking at fifth lumbar trabecular bone, we had almost similar picture in all these terms of these both at these trabecular parameters we took it. Now, we say that trabecular microactive degradation happens with calcium deficient diet, and it is partially reversible. It's not a completely reversible. The question arises, which we shall later, why it is happening and why it is resulting. Is it resulting to poor bone strength? Now, we did a cortical bone analysis also, the femur cortical bone in the control group, really thick cortex at the femur. In the calcium deficient, the thinning of the cortex in the calcium deficient at P150 and 210. In calcium replenishment, there much improvement. In this, if you compare this and this is much lower. Similar things in the tibial cortical bone. And when you look at the tibial cortical bone, femur and tibial cortical bone, calcium deficient diet had at the femur, reduced total area, cortical area, increased medullary area, and cortical thickness was lower. And the same kind of picture happened in the tibia. When we look at 210 days actually, still calcium deficient diet had significantly lower parameters, but there was a recovery of cortical parameters which is at par with the control groups actually. Looking at cortical BMD, there is a recovery of the cortical BMD at the femur, recovery of the tibial cortical BMD, getting close to the normal, but not exactly normal actually. So calcium deficient diet negatively affects the tibial and cortical mass and other parameters at P70. Our cortical parameters and mass both were reversible, how in some areas they were partial upon calcium replenishment. Now, looking at the strength of the bone, this is the most important slide of the whole work actually. We looked at the maximum power, energy, and stiffness, and we look at despite supplementation, the maximum power, energy, and stiffness was significantly reduced in all these subjects, showing that the strength of these bones really re- remains low actually. We looked at the compressive strength at the femoral head and almost similar kind of picture on maximum load, energy, and stiffness. And when we correlated the maximum power with the BMC of these bones, actually, there was a there was a positive correlation of maximum power with more mineral contents, means that the bones translated to the calcium content of the bone. L5 vertebral compression test again showing the similar kind of picture and the similar kind of regression analysis we had. So the summarize here is that calcium deficient bone had a significant reduced bone strength, which even after calcium supplementations remain reduced. Thus, calcium supplementation failed to afford significant strength gain over calcium deficient group. Now, what really happens with tissue mineralization in this? We carried on the bone histomorphology. I'm thankful to Dr. Ritu for providing this facility to our student actually. And this is how the single and double calcium labeling, and it shows the control. You can see the double labeling, single and double labeling of calcium at these areas actually, and calcium markedly widened calcium listing. And even a calcium replenishment, there is a widened calcium means osteomalacia is not completely recovering. This is quantitative histomorphometry, so the single label surfaces, double label surfaces, MS versus BS, mineralization position rate, and bone formation rate. It shows that there is a recovery there is a recovery of the single label surface, recovery at the double label surface after calcium replenishment. However, the the MSBS were remained significantly low. Mineral opposition rate was resumed proportionately, but BFR was significantly lower as compared to the controls actually. So summarizing this, a calcium deficiency it decreases bone formation rate, mineral opposition rate, MS by BS, and replenishment shows partial reversibility compared to the controls. Calcium replenishment at P150 and 210 shows partial recovery in bone formation parameters, although significantly higher in calcium deficient group. Overall, calcium deficient group, the recovery profile at P110 was better than 1 P150. So this is Goldner trichome staining showing the osteoid staining actually with the Goldner act, and it shows that even at the calcium replenishment, there was still lot of osteoid present, which is as compared to control group, there was much higher in the osteoid actually. So there was an increase in the osteoid tissue, including osteoid area and the width in the calcium deficiency and osteomelic condition. Calcium replenishment failed to reduce the calcium deficiency induced increase in osteoid area, which persists of osteomalacia. What happens to the bone biochemical parameters? Thankful to Dr. Naveda for getting this done from IIT Kharagpur for bone biomaterial properties by the scanning electron microscopy. This is a control group at P70 210, calcium deficient group at P70 210, and this is calcium replenished group. And the tissue calcium in the section of femur metaphysis measured by BE mode showed 50% lesser values in the calcium deficient group at P70 and 210. So tissue calcium is significantly lower. It recovers but not adequately in this. Then we looked at axial diffraction analysis. We looked at half max, full width, half maximum. If it is high, then it is poor crystal packing, and it is the higher value than the normal shows poor crystal packing actually, as you've seen in this figure. So again, the same theory goes into the practice that calcium replenishment failed to fully resume both material properties. So if you look at the overall picture of results, actually, we have got recovery in the growth in the femur, but not in the tibia. Biochemistry, serum and urine improves, but still we had a hypophosphatemia in these. Bone turnover markers, they improve. Microarchitecture improve with a partially or still not completely. And bone strength, we have got difficulty in the bone strength remains poor actually. Bone restoration shows partial recovery in the osteomalacia pattern actually, and histology we have still osteoid area. Biometric properties fail to fully restore bone biometric property, and therefore, the recovery at the 210 days in the rat model is still incomplete. Maybe it may be possible it remains for the whole of the life, or it may improve gradually over a period of time actually. So, what does it mean in clinical practice? It means in the clinical practice that if you have a calcium deficiency in a young age, you are going to have a lower peak bone mass and therefore more propensity to develop the osteoporosis in the early age group. The important thing is that are we looking at a BMD or the bone strength? Does it mean that if you have a calcium deficiency in the childhood, lower peak bone mass, we have a lower BMD, no doubt, but do we have increased fragility even with a higher BMD? Because BMD tells you calcium content, it does not tells you the microarchitecture. So it is a very strong possibility that BMD may improve, but microarchitecture may not improve, and this would be reflecting in the sense that we are having vertebral fractures and hip fracture at much earlier age in Indian population as compared to Caucasian population. So it's still the philosophy between the BMD and the BMD parameters and the microarchitecture remains unresolved. How does calcium deficiency in childhood may reflect poor microarchitecture in the late stages of life? Thank you very much for patient hearing. This work was done by my student, Dr. Shivmurati Yadav, with the great help of Dr. Navidya Chattopadhyay, Dr. Ritu Divya, and Dr. Suwasi from Molecular Medicine, Dr. Godbole and Rohit, and and Department of Chemical Engineering, IIT Bombay, Dr. Jayesh and Dr. Deepak. And so I acknowledge all these great friends to contribute to this work, and this paper was published in the board. I'm really thankful to the whole team for carrying on this work. Thank you very much, Professor.
Thank you very much, Dr. Gupta, for giving this such a lucid presentation. And indeed, you have shown the translational aspect of calcium deficiency and how it relates to human condition, which for not only India but also for all the developing countries is a cause of concern, which the government must or the medical community must take much serious note of. One issue I find, although I'm not a clinician, but at the various clinical fora of India, I find the vigorous discussion on vitamin D deficiency despite abundant sunlight in India. But what is happening in India is that on the one hand we say that because India being a sunny country, there is a vitamin D deficiency. But at the other hand, India is the largest producer of milk in the world, and we have dietary calcium deficiency that actually causes secondary vitamin D deficiency. So we find lot of advocacy for vitamin D fortification, but not much aggressive tone is found in case of calcium for supplementation. So since you are in various committees of ISBMR and Endocrine Society, what kind of policy decision should be given to the government about tackling calcium deficiency?
Can I speak out now with it?
Please,
I'm not.
please. Yeah.
I'm not hearing you.
Pardon?
Should I speak out?
Yeah, yeah. Please, please, please.
Actually, the perception is that my hunch goes that we do have vitamin D deficiency because of many reasons. We know them, but calcium deficiency is because of poor nutrition intake. We are the biggest producer of milk, but we are the biggest population in the world also. Per capita, dietary calcium intake is terribly poor. There is huge discrepancy of the dietary intake between the lower and upper social status. Even in the upper social status, the prevalence of lactose intolerance is pretty huge, almost 40%. So they avoid the milk. So we are, in some people, we have got a problem with scarcity. In some people, we have got a problem with the plenty actually, or plenty. So there is a huge discrepancy. Calcium deficiency is not farmer-driven enterprise. Vitamin deficiency is farmer-driven enterprise actually. So a lot of emphasis being have been put on vitamin D, but without adequate calcium, vitamin D won't have that kind of substrate to build up the bones. That's a problem here. We are not trying to push calcium deficiency as a big medical health policy thrust area. We are pushing vitamin D more often. Availability of calcium through milk or tablet is a huge phenomenon as far as nutrition is concerned because it has to be multiple times in a day, at least 1 or 2 times in a day. It has to be 365 days in a year. It has to be round for many decades to have optimal bone growth, which is not practically achievable in the such a huge population. So calcium deficiency is more of a nutritional issue. Vitamin D you give once in a month or once in a week, it's fine, but not calcium cannot be given once in a week actually. So it's more not easily manageable. It is more of education. Even when I practice osteoporosis in elderly age group, 70% of women don't take milk more than 300 ml, 400 ml per day actually. That's a problem. And they have been not taking milk since their childhood. So there are many factors actually.
Hope taking note of your finding that calcium calcium deficiency during growth, during the stage of peak bone mass achievement, this deficiency, the impact, the skeletal impact remains. It doesn't, or what you have very nicely coined as a as calcipenic memory, that the calcium deficiency memory stays in bone despite its restoration in later stage, is something. How you can really now translate that into human, that by that I mean, how are you going to check or test if the finding in rat also is true in human?
See, this concept came from glycemic metabolic legacy actually, or glycemic legacy actually. It was a very bad glucose levels in early stage of diabetes. Even if you control diabetes pretty well, it leaves an imprint for developing the complications. So if you have a calcium deficient in the early age, then probably you are not going to have the adequate bones even after replenishment. Your bones shall remain fragile actually. So the whole lesson is that strike in the early age hard, give them optimal nutrition intake to have to avoid the long-term effects of calcium deficiency later in the life. So probably calcipenic memory carries on till the late ages of life and really may predispose to the high prevalence of osteoporosis and fractures.
But do you think that the similar situation exists in human? Do you think that some prospective study, if it is possible to do any prospective study to test if calcium deficiency correction at a later stage in human still keeps the bone impaired, or do you think any retrospective study is possible? I'm just wondering that can this finding, preclinical finding, be substantiated in human condition?
One can do one thing actually is for humans, a long term study of such long duration is not possible. One can look at calcium intake, look at a postmenopausal woman with a history of poor calcium intake and woman with good calcium intake. Those are two key points. Look at their HRPQCT, look at a bone mark architecture, bone strength. But again, good calcium intake is a reflection of good protein intake also, good nutritional intake per se, overall good nutritional history. So it is not only calcium which is going to be alone, it is going to be multiple nutrients actually, of which calcium is one of the part. So it's possible that if we look at from that viewpoint, that poor calcium intake and other parameters are closely matched, then we can. So we look at the people who are lactose intolerant actually. Their restaurant diet is okay, but but uh, calcium intake is low actually. So one look at by HRPQCT and BMD, what really difference is.
Okay, if there is any other question to Dr. Gupta, please feel free to ask him. Any suggestion, any comment, any question? I don't see any hands. Hand. No, I don't see any hand raised. Okay, so if there is no more, yeah, please. It doesn't look like there is any comment or question. So let me again thank Dr. Gupta for this lucid presentation, and this presentation has been recorded. So in a few days' time, you will get a copy of this recording. Thank you very much for your time.
Thank you, Navada. Thanks all friends. Thank you very much.
Thank you. Bye. Bye.